we move ahead, we have a slight change in the program. Stefan Baral will be first, updating you on what happened in Mexico on treatment. He doesn't. I think you don't need an introduction after this morning. Okay, floor is yours.
Same intro as earlier. So we changed around the order a little bit, and so Dr. Terlikbayeva will give the talk on prevention and testing after me. So this talk is actually a summary of AIDS 2016, 2017, 2018, and 2019 on treatment. And I just thought that actually presenting 2019 without the earlier studies might be challenging. So I'll just try to quickly synthesize all of it. I still have no financial disclosures since this morning. So I'll just start by talking a little bit about what we know about like the individual benefits of ART, and now I think what we have a really good handle on population level benefits of ART. And I think it's particularly important also based on the conversations that have been taking place over the last few days about really scaling up treatment. I'll then talk about actually some of the really interesting data that were presented building on what Andre was talking about in terms of long-acting, two-drug regimens, as well as the update on dolutegravir and some key themes. So, you know, I think we're now clearly in this era of U equals U, where we've heard this undetectable equals untransmittable. And that's really based on 3 studies that have come out. The first study was reported at the 2016 conference in Durban, and that was the Partners Phase 1 study. So these were heterosexual serodiscordant couples that were reporting condomless sex. And basically in a clinic cohort across 14 countries in Europe. And what they found were after 36,000 reported condomless sex acts, there were 0 link transmissions. And so it sort of started giving this idea, I think, building on what we knew observationally, that if somebody had an undetectable viral load, whether they use a condom or don't use a condom, there's no risk of onward transmission to their sexual partners. The next 2 studies focused on MSM, gay men. So the first one was opposites, or I should say they came about at the same time, but opposites attract was a study that was done in Australia, Brazil, and Thailand, including 343 gay couples with 16,000 condomless sex acts. Again, serodiscordant couples with one person, the person who's living with HIV, achieving viral suppression. And there was no link transmissions. And then most recently at the AIDS 2018 meeting in Amsterdam, there was the Partners Phase 2 study reported, which was 780 gay couples across Europe, again, with 77,000 condomless sex acts, again, serodiscordant and condomless sex acts, and still no transmissions. So I think at this point, nobody doubts the idea that U equals U, that if somebody's living with HIV and they have viral suppression, that they have no risk of onward transmission. And that builds on these sort of 3 earlier studies that I also think are important to remember. So HPTN 052 was a very famous study that was done, now reported at the IAS 2011 meeting in Rome, where there was this 96% reduction in sub-Saharan Africa if people had access to early treatment versus late treatment. And then there were 2 more studies that came out. Temprano was a study with HIV and tuberculosis done in Cote d'Ivoire, also showing lower mortality among people living who are co-infected with HIV and tuberculosis with early access to treatment. And then finally, there was the START study, which focused also on comorbidities and mortality and morbidity among people living with HIV, also showing really important benefits of treatment. So that started off this group of these population level studies that have been done. And I think now over the last 3 years, we've seen the last of these, and I'll say collectively, these represent about $500 million or $500 million US dollars of investment. So I think it's really important that we look at these results very carefully and we try to really see what they mean, because there'll never be studies like them again. They were so expensive that they'll never be repeated. And in fact, these will represent probably the biggest research studies that have been done for any disease ever. The first one reported out at the Durban AIDS conference. This was a French-funded study, the ANRS 12249, also called the TASP study. I will note that Joop Lang was I was at a meeting with him once where he talked about really concerns about the language of TASP, the idea that you would use treatment as prevention rather than treatment as treatment with a secondary benefit of prevention. And so I've always sort of reframed these either as universal coverage of treatment or universal treatment studies. But nonetheless, I thought that was a really important, it's something that struck me. But I'll say one of the underlying idea for this trial was that in this part of this was done in South Africa, in KwaZulu-Natal, where there's incredibly high prevalence, and people were concerned that people had to travel too far of a distance in order to access HIV treatment. So what they did were put up little pop-up treatment shops so that people living with HIV would never be more than 2 kilometers away from a treatment facility. And they could go further if they wanted, but they would be no more than 2 kilometers away. And they did this, very quickly. They already had the sort of site set up. And so, again, in the intervention arm, they made these treatment facilities available everywhere. In the control arm, it was just the standard, normal government-supported treatments. And if you look at it early on, you can see that actually they had this really important increase in treatment initiation within 3 months of 90% versus the control of 50%. But after about a year, they reported these results actually at the AIDS 2015 meeting. You could see that after about a year, only about half the people living with HIV still were engaged in treatment services. So there was an initial bump, but then it looked very similar. And then that resulted in, I think many of us predicted what happened in the end, which was that there was no prevention benefit, no incidence reductions at the population level with, over total 20,000 person years associated with treatment. So this was like the first study that kind of came out and put a little bit of chink in the armor of the idea that treatment would act as prevention at a population level. More recently, the Project Search study, these were results reported out at the Amsterdam conference in AIDS 2018. So this was a huge study that was done in Uganda and Kenya with over 300,000 people. So just an incredible, these studies are so large, that they sometimes almost represent the populations of small countries. But the idea here is that they wanted to use a multi-sort of disease model, that they felt like people won't come in just for HIV treatment alone, but if you can manage hypertension and diabetes in addition to tuberculosis, that people will be more likely to engage. And this was a study really focused on trying to engage men, right? The idea that men were not engaging. So they did this really large study, and I think there was a lot of things that worked really well with this study. So, tuberculosis incidence in their experimental arms came down dramatically. So they screened and provided treatment. The overall mortality among people living with HIV came down in their control arms by about 25%. So they were able to lower mortality. And also, by the way, hypertension also did better. So they were able to control high blood pressure among people living with HIV. Importantly, they also were able, this is the sort of 73. Yesterday we heard, 90, 90, 90 becomes 90, 81, 73, as Dr. Supervi said yesterday. So in their experimental arms, they hit the 73% viral suppression. So they hit 90, 90, 90. They did not do that in their control arm. So, in the end, they worked to be able to put more people on treatment in their experimental arms. But when they reported their incidence results, again, there was no difference between the treatment arms and the control arms in terms of overall HIV incidence. So this was another sort of concerning study that showed that overall there was benefits, but there was no difference between the control and experimental arms. And then finally, there was sort of the big one, which was pop-art. And pop-art was, the final results were reported at CROI as well as at the IAS conference. So this was the biggest of them all. This was in 21 different clusters across 2 countries, South Africa as well as Zambia. And I'll just say there was 3 main arms in this study, but overall this study included more than 600,000 people. So truly, an unbelievably large study. The cohort alone of what they enrolled were 55,000 children, and like I said, over 600,000 people. And they went door to door in these people's homes and tested them, and then provided access to treatment at their home. So basically they had Arm C, which was the standard of care, which was 7 communities. Arm B, which was basically only testing, but no treatment, but also providing circumcision and other services. And then finally, Arm A, which was like treatment and testing. And I'll just say that when they reported their results, this is the control arm. You can see that in the prevention-only arm, where they provided prevention services but not treatment, they actually did see a reduction. But in their treatment and prevention arm, they saw no difference between arm A and arm C. So again, there was no incidence reduction associated with treatment at a universal level. So we could have a much longer conversation. People are trying to understand these results. But I think it's also important to say that these results, this is sort of a summary of them, that at individual levels, you see this is sort of 1, which means no significance. At individual levels, we know that treatment lowers morbidity, lowers mortality. Of that, there is no doubt. But at a population level, these 3 studies now have not shown population-level declines associated with treatment. And that's very consistent with what we've seen, by the way, at a country level. So these are 3 countries that are heralded as successes in sub-Saharan Africa: Botswana, Rwanda, and Ethiopia. And you can see in the red line here, this is treatment uptake. So each of these countries has hit the 90-90-90 targets. And you can sort of follow that along. These are from 2010 over to 2018, which was the most recent available data. So you can follow these red lines and see that they've done very well. But in blue line is their numbers of new infections. And you can see that these are basically steady or slightly increasing. So again, they've achieved treatment and people are living longer, and that's fundamentally important, building on the talk we heard yesterday. But it's also important to say that it hasn't gone down. Incidence hasn't gone down in the increase with treatment, at least over the last 7 to 10 years. And that's not just true in low and middle income settings. These are data from the United States. Here what they've done is basically split up the 50 states of the United States into 5 quintiles. So 10 states in each according to PrEP uptake. And what you'll see is, by the way, this is what the treatment cascade looks like in the US, which is that it ranges between 52 and 60% viral suppression across the United States. But the point I want to make here is a different one, is that if you look in the states that have low PrEP uptake, okay, independent of viral suppression, you can see that there's been a steady but slow increase in the numbers of new infections. And it's only in the states with higher PrEP uptake, right, that you can see this decline from 2012 over to 2018 in new infections. So again, it tells you the story that there's no doubt that treatment is important and people are living longer, but it hasn't at a state level reduced incidence. And the only thing that has really achieved that has been the upscaling of PrEP over the last number of years. And again, the last country I'll show is the United Kingdom. So for the time being, this still does represent the UK. We'll see in a few months what the UK looks like. But for now, they have a kind of a collective reporting system, which makes it very powerful. And here you can see numbers of new infections. These are data from Valerie Delpeck and others at Public Health England. You can look at infections from 2007 to 2016, and the same. This is basically all the other settings, and this is London. So we know London is where most of the infections are, but in all of these settings, actually treatment uptake is very, very high, right? Treatment uptake has been high for the last number of years, and you can see even with high treatment uptake, you've seen a steady but slow increase in new infections in London. And it was only in the last few years where they started doing self-testing and PrEP and other things, only really in London, that we've seen this really amazing decline, but we've not seen those things in other places where they're not really doing PrEP and other things, but treatment uptake is incredibly high. So I just want to sort of present some of these data. By the way, this is true in my city of Toronto, it's true in Vancouver, it's true in the settings where we have high treatment uptake, but really, and France is another great example, where incidence is actually kind of steady, even in the context of high treatment uptake. So we could talk more about that maybe in a discussion forum, but I'll leave that for now, given the fact that I'm probably already running over time. Andre already sort of gave away the punchline of this. I will say that, I mean, dolutegravir may be a drug that is familiar to folks, but dolutegravir is an integrase inhibitor that really is intended to replace tenofovir as basically the base for a lot of our treatment regimens. And it does that because it has a higher barrier to resistance, it's cheaper, it's easier to use, it has less adverse effects, it doesn't affect the kidneys in the same way as tenofovir-based regimens. And so there's been a lot of excitement, but, with this initial data from Botswana that came out at the AIDS 2018 meeting, there was this concern about increased neural tube defects. And, there was warnings issued from the WHO. Countries, said we're not doing dolutegravir, we're not switching, et cetera. And so what they did, they presented the updated analyses from this trial. And the punchline has already been said, which is that actually there was no difference with neural tube defects in dolutegravir versus TAF, which is a tenofovir alafenamide, a derivative of tenofovir, or efavirenz-based regimens. And in fact, even though it's not significant, there was a bit of a lower level of neural tube defects, in the dolutegravir-based regimens. But really importantly, and they also compared against people that don't even have HIV, so obviously aren't even on treatment. And again, there was no difference in neural tube defects or between them and people who were HIV uninfected. That's great, no problem. So moving on, so I'll just say, I think I'll just make this point and just highlight it again, that dolutegravir, there's no, that story it's almost derivative. It was something that people got kind of excited about, but I think has really been put to rest with a number of data. I'll just say they've updated these data now from Brazil and from Botswana and other places where they had early uptake of dolutegravir, and it's really not been seen in any setting. This example was a single neural tube defect that happened, so compared to none, but the numbers are incredibly small. Four pregnancies. Okay, sure. So I'll just say, just to finish on running out of time on a few elements here. So one is that the two key things that I'd say people should pay attention to are this idea of dual therapy versus triple therapy. And long-acting formulations, and I'll just sort of finish with those. So this is basically a look at the pipeline right now. So the only thing that I think to keep in mind with the pipeline is that there's new antibodies that are being developed for treatment that I think are interesting. There's one that's already been approved for treatment, but only for multi-drug resistant HIV. And then there's these two-drug regimens, so dolutegravir and lamivudine, and dolutegravir and rilpivirine. And so, when you look at the trial data, so these are data from Gemini and Tango. These are both evaluations where you took people who either were new initiates or switched from triple therapy to dual therapy. And the punchline, I think, just to say very quickly, is that people do seemingly just as well on dual therapy, either when they get initiated or even folks who get moved from triple therapy to dual therapy. So I think the implications, this isn't maybe ready for prime time yet, but the implications will be significant in terms of lower adverse effects, lower costs, obviously, because it's less drugs. So, there's now a couple recommendations. The IAS USA basically will say that right now, the only time that they recommend dual therapy is when people can't use abacavir, tenofovir alafenamide, or tenofovir. But, that may change over time as we get more data on dual therapy. I will say that pharma maybe is less excited about these trials because obviously they would involve the sale of less products. The last thing I'll talk about is FLAIR and ATLAS. And so FLAIR and ATLAS were both evaluations of long-acting antiretroviral drugs. And so this is really cabotegravir. Cabotegravir is a long-acting version where you would have injections every 8 weeks of a couple mils into the buttocks. And so these are, in this study, it was ART naive patients. In this, it was actually a move from people who were virally suppressed. And the point here, again, is that long-acting drugs actually for treatment do very well. I think for prevention, it's a more complicated story. But I will say that people do very well on long-acting drugs. And for a lot of folks, this may help with adherence issues, although much more complicated supply chain management because these are injections, they are painful, but you would only need to provide them every 8 weeks for folks. So I'm just going to, I guess, finish by saying, we talk a lot about the end of AIDS. This was the 2020 goal. We're up here, and we're now 42 days as of this morning from 2020. So I think, we recognize that we're now triple the numbers of infections that we had hoped to be at in 2020. So I think when we think about treatment, we need to start also thinking about treatment as treatment, but other prevention strategies as really being fundamental to lowering HIV incidence. And so just a few thoughts. So one, there's no doubt that universal treatment is important. It extends life, but it only prevents HIV infection if you treat somebody who still has a risk of onward transmission to somebody else. So that's a little bit of a different framing that I think is important to consider. I think emerging treatment strategies include longer-acting drugs and true drug regimens. And I'll just say as a finishing point is that, we focus a lot on 90-90-90, but a lot of these data tell us that actually it's probably more important to understand who you're treating than how many you're treating when you think about it from a prevention perspective. And then so when we think about what that means in terms of implementation about addressing those most marginalized into treatment strategies probably just becomes fundamentally important. So thanks very much.
Thank you, Stefan. There's opportunity for a couple of questions. Yeah. Questions from the floor.
One question I was asked this morning in the context of U equals U. So what is viral suppression to you? Less than 1,000 copies, 500, 200, or 50? Because here we have different machines. And the question was, should they repeat this, viral load test using better equipment? Thank you.
Yeah, thanks. So I think it's really important that we highlight the word undetectable. So WHO defines viral suppression as 1,000 copies per mil, more as a practical outcome. But for U equals U, this really is less than 50 or maybe even 20 copies per mil. I would not feel comfortable as a clinician if somebody was hovering in 800 copies a mil that they would have no risk of onward transmission. I think I don't know that we know the answer to that, and I think it's a really good point. In places where we don't have good viral load data and other things, I would be very hesitant about that strategy, and I think it's a really important point. So these data, when they talk about the 0 infections for undetectable folks from partner 1, partner 2, and opposites attract, those were undetectable, which means less than 50 copies, and in the opposites attract, I think they were using 20 copies. So yeah.
This is also a question from one of individual living with HIV. It's about dolutegravir and weight gain. Is it possible? Is this the case? Because it was a young, pretty girl, and she was concerned about this weight gain. Thank you.
So I think that yes, the short answer is yes, and I think that part of this is, I will say, the benefit of working. So I mean, to Kate's point, actually, my clinical work is all in Canada, so I don't have to worry as much about how folks have access. But I will say that one may make decisions based on a few different things. One is, you have options based on who the patient is, what their goals are, what their resistance is like, et cetera. And, sometimes what we'll do is if we want to use dolutegravir, obviously we have other choices, but if we wanted to, we would also talk about a regimen to try to avoid weight gain, et cetera. But yeah, the clinical findings show that there is weight gain associated with dolutegravir. And so, but I think so that may be an issue. I think you can avoid it. But I think it's important to counsel patients about things like this that they should expect.
Is this just weight gaining, or this is like redistribution of fat?
It's not lipodystrophy, yeah.
No,
so it's not
just weight gain.
Yeah, it's similar to olanzapine, like some of the typical antipsychotics that we use that will have weight gain associated with them. So, but it's not lipodystrophy. It's not the fat distribution with the old stavudine and older drugs that was a major issue. Yeah.
У меня такой вопрос. Вы говорите о ПрЕПе, а у нас в Грузии я слыхала ПЕП тоже, Post-Exposition Prevention. Уже не применяете или как? Спасибо.
Yeah. I don't want to take away from Dr. Terlich-Baev's talk. Are you going to talk about PEP? Yeah, then I'll defer the question to my colleague, because the presentation on PrEP and PEP will come right after mine. So I just don't want to take away. You know.
I have a question myself. There is a corollary. I mean, the data that you showed about treatment basically not being prevention. There is a corollary with TB, because I think in the 1990s the idea was that the DOT strategy would bring down TB incidence by sheer early treatment, and that didn't happen. But the models did suggest it would, predict it would, and that basically showed us how flawed those models were in terms both of their structure and their parameterization. So does it mean that we have to go back to our models in HIV?
Yeah, I mean, so, you know, the models that included, so this is a really important point. The models used the HPTN 052, 96%, you know, it didn't include the complexity around the migration issues about why people migrate. It didn't include elements of like concentrations of risk, like among MSM or people who use drugs or sex workers who are moving around for work, et cetera. It just said if when you put in treatment, even Optima, I saw Optima being presented today or maybe this morning, you know, and the Optima model in terms of like cost efficiency uses this 96% benefit. And so one will say that sometimes it predisposes the idea that the most effective thing is just to put everybody on treatment. But I think now that we have these new studies, we should reevaluate the structure of these models. And so I can only say I think that's fundamentally important, that we shouldn't ignore them because they don't support what we like. And it's not to undermine treatment. Treatment is fundamentally important, but treatment and the end of the pandemic may not be exactly the same goal. They may be like two separate goals that are like friends with each other, but not the same thing.
Well, if you allow me one more comment, I mean, I think the issue is not ignoring them because they don't support what we say. They basically are flawed because you actually have, the prediction has come out, it hasn't worked. So that means that they are essentially flawed. I mean, you basically now have empirical evidence.
That's right. Yeah, I think that's exactly right. I think that I worry that the global community isn't talking a lot about these trials, even though the investment into them was huge. If they had all shown massive incidence declines, that's all we would talk about. I think because they haven't, I know our time is over, so I just want to finish by saying that those studies were really well done, and I think we should be using them to parameterize our models and to inform our programs.